Thank you. I'm presenting on behalf of Alison because unfortunately she couldn't be here with us today. And thank you to the chairman and ladies and gentlemen. Good afternoon. We have nothing to disclose. Okay, so the purpose of this study was primarily to look at defecatory dysfunction, so we'll bring a bit of bowels into the mix today. So we know that defecatory dysfunction is multifactorial. It can be both anatomical and functional, and imaging of these can allow us to assess any abnormalities. The gold standard currently is defecating proctography. So we use total pelvic floor ultrasound, and we use transvaginal, transperineal and transanal probes to assess multi-compartments, so we can assess the anterior, middle and posterior compartments in the pelvic floor. This is just a slide to show at the top, going from left to right. At the top is the images we get from the ultrasound, and along the bottom are the defecating proctogram images. So the role of ultrasound in comparison to MRI is similar in that it doesn't use radiation, but it's much cheaper and readily available and portable, so it can actually be done on a one-stop clinic to assess compartment failure. So the primary aim of the study was to assess the accuracy of total pelvic floor ultrasound when using defecatory proctography as the gold standard, and we were looking at anatomical abnormalities in rectocele interceptions and functional, as in poor dysynergia, poor propulsion, So we looked at secondary aims as well. We also wanted to look at the agreement between the pelvic floor ultrasound and the proctography results and correlation of the two. We did look at cystoceles, but for the purpose of this study, we just concentrated on the rectoceles and interception and enteroceles. The method of the study was prospective. We had 224 women, and we looked for the presence, the size, and the grading of rectoceles. Both studies were reported blinded to the other. From the results, we found there was fair comparison between the two, with rectocele having a good comparative result between proctogram and ultrasound. And also, when we looked at the sensitivity, we found that there was a good sensitivity for the presence of rectoceles, but the specificity for enteroceles interception and poor coordination was better. So rectoceles that were trapping on proctography were definitely, we picked those up straight away on the transvaginal and the transperineal ultrasounds. Those with poor coordination and propulsion on ultrasound were more likely to display incomplete evacuation on proctography. So, in conclusion, we found that if an enterocele or interception or poor propulsion is present on ultrasound, we're likely to see it on proctography. And if the rectocele is seen on both transvaginal and transperineal, it's more likely to be a trapping rectocele. And also, we concluded that this is a good initial screening tool in patients. If they do have a large rectocele or enterocele, we can then go on and perform a proctogram. Thank you. Any questions?
Any question? This is very interesting presentation about a new modality to approach complex pelvic floor disorders. Do you think could be associated with also the evaluation in the anterior compartment as well as a...
We are doing studies to look at that as well. We're looking at the anterior as well and comparing it to urodynamics and other studies. So hopefully that is an ongoing thing. Yes.
Because actually to evaluate all the pelvic floor, anterior, apical, and posterior, the MRI, the dynamic MRI, looks to give an overview of the different compartments. So, but it's time-consuming and also cost-effective. So probably the opportunity to evaluate, to assess the pelvic floor with the ultrasound is more specific. The problem is how many experts they can be utilized for assess this kind of complex evaluation, because it needs to have knowledge about bladder, about uterus and
I think we have a large cohort of patients that have both urinary and bowel abnormalities, and we found the anterior view of the transvaginal. We can at least look at initially bladder neck descent. You can also pick up cystocele on this initially, just as straight away. So then they can then go on and be referred. But hopefully we then integrate it all and we'll be able to make a much more rounded conclusion just from the ultrasound.
Which is your main specialty?
Sorry?
Your main specialty. You are a specialist on what?
Colorectal.
Okay. Thank you.
Thank you.
Thank you.
Well, thank you very much.